Huh. Reading. تشوفون الكتابة؟
شوي يبين
دكتور
صغير دكتور بس ما مشكلة يعني
أي صح يبين صغير.
هسه يبين لو زين.
يا سيدي أحسن.
تمام. راح تشوفون كثير من هاي البروتوكولات، يعني عندنا تقريبا 90 بروتوكول في النيوناتولوجي وحوالي 78 في البي اي سي يو. ف we have a protocol for every care or procedure or protocol or maneuver or disease that we will deal. There is a clear protocol. Okay, so this is an example of care of extremely low gestational age infant. That's mean any baby below 100 grams or beyond or below 27 weeks. هذه guidelines لهذا البيبي. تمام. فيقول لك الجايد لاين، يقول لك purpose of this guideline, the outcome that we are expecting, and what is the initial management. So it describes the initial management, what we should do, and the checklist that we will have. So when we expect a baby less than 100 grams, we meet parents, explain the outcome, sign them on documents. We also talk with the obstetrician before, and then I update the obstetrician after delivery. We have a checklist that we fill, and then we will go to the room. We prepare order sheet. We have a standard order sheet, so an order that we should be done to this baby. Also, we go to the delivery room. We increase room temperature. So any baby less than 1,000 kilograms will never survive if the temperature of the room is below 23 weeks. So we have to set the temperature, for example. Okay, and then we change the temperature at least like 1 or 2 hours before the delivery. Okay, so these are examples. We prepare the warmer, so we will learn what is the warmer, humidifier, and the tubing of the ventilator. Intravenous solutions are a blanket, it's warmed and ready. Transport incubator, warm to 37 degrees. And then we plan the delay cord clamping. We bring the plastic bag to cover the baby. We'll teach you that. We prepare CPAP, transport CPAP if already. We also monitor the temperature. Inshallah, يكون عندنا protocol of thermoregulation. We should have a SAT monitor. We should also plan the target monitor. For example, you can see the target here, 88 to 99. Now, of course, you don't need to memorize this. You will have it, and you can read it with each baby. So you don't need to memorize it. Nobody will ask you. Also, we'll prepare ourselves to insert UVC and UAC. We also need a chest X-ray maybe, and also cardiorespiratory monitor. Okay, in these babies, we avoid alcohol and chlorhexidine. Usually we sterilize the baby with normal saline. So these are the management before the delivery. So that's what we do before the baby even deliver. Then we have a management during transport. So what we do the baby during transport. You can see we didn't talk what is the actual management, like what we will do in the labor room, because we will have a resuscitation of a baby. But here, just some guidelines how to be ready. So what exactly we need to do during transport, okay, and how we continue the management, okay, and then the ongoing management, and how to control the temperature of the incubator, and how we increase the temperature, and then how we decrease it with baby life going on. And then how we care the skin of the baby, what exactly we need to know to prevent skin damage, because these are very, very small. Okay? So you can see all this. How we do developmental care, and developmental care is meaning that how the baby is lying, how the light, the noise, how the baby sleep. These are the development care. So we will learn in the future. And then we go to the checklist that some people ask me about the checklist. So we'll have each disease, we will have a checklist. Okay? So you can see this is a checklist. So the nurse and the doctor start to put. So first, for example, do we know the mother age? Okay? So that's required.
Yes.
And what is the gravidity, parity, and abortion, if there is? Second is, for example, here, what's the mother blood group? Any previous history, whether obstetric or medical history. So any like a previous obstetric problem, bleeding, death, hypertension, diabetes during pregnancy, and other, there is another C-section here written. So if you think we can document, if we already take it, this checklist doesn't mean that should be here, but it's already taken. Previous history we know. And you can see here also ultrasound report. And when we have ultrasound, we need few things. Okay, so first thing we need from ultrasound is we need the Doppler. So the most important for me when I look at the ultrasound, I need the Doppler. Is the Doppler checked or not? What exactly I need from the Doppler? Is the Doppler normal? Is it absent diastolic flow? Is it reverse diastolic flow? And it should be the flow in the uterine artery, umbilical artery, middle cerebral artery. And also we need the resistance index and pulsality index. So these should be checked. That is already recorded or changed by the doctor or by the obstetrician, whoever. Okay? Also, we need from ultrasound, we need the XO, we need the Doppler and the detail of the Doppler. We need the expected weight. What is the expected weight by the ultrasound? We also need by ultrasound to tell us what is the expected gestation, any malformation, and the amount of the fluid around the baby. Okay? We need something called GPS screening. Did they do vaginal swab for the mother looking for group B streptococcus? It's an infection in the mother that causes sepsis in the baby. So we need to know, is it done or not? And if it's done, is it positive? And if it's positive, treated or not? So negative and not. So it's done or not? Negative, unknown. So that's mean done. It's not done, and there is no result yet, or we don't know whether it's done or not. And the most important also, we need to check whether the mother is in labor or not, because prematurity without labor, there is no need for antibiotics. But the prematurity with labor, there is need for antibiotics. Then we need to know the mode of delivery. Is it normal vaginal or assisted vaginal or C-section? And if it's assisted vaginal delivery, is it forceps, vacuum, or they use others? And then we need to check, is the mother have any psychiatric problem? Because if she has a psychiatric problem, she will take medication that can affect the baby. Is she smoking or drinking alcohol? Hypertensive, diabetic, any other maternal condition, previous history of prematurity? Okay, so she has a previous baby premature, either previous history of abortion, any previous neonatal admission to the NICU or death? So yes or no? Is the mother leaking? So is the membrane ruptured? And if it's yes, what is the duration, date, and time? Did have any urine culture or blood culture? If she's on antibiotics, which antibiotics? Did she receive antenatal steroid? Antenatal steroid is very important for the outcome of your baby. Did she receive magnesium sulfate? Very important for the brain of the baby, if the mother received. So these are the checklist. First checklist is what exactly need before the baby deliver. That is not a must to be from nurse's point of view. But the doctor, when the doctor did that, you checklist. You check that the doctor already done. Then we need to arrange, we have a checklist for arrival to the NICU. So we need to prepare the NICU for the arrival of the baby. So for example, the incubator, we need to set the temperature of the incubator 37 degrees Celsius. We need the humidity to be 90%. And the water irrigation of the incubator should be filled. We need a temperature probe, central and peripheral. We need flow meter to measure the flow. We need ambu bag. We need a mask, circular mask, not the mask with notch. So it should be circular with cushion. And we need 2 0, 0, and 1 0 size. So this is the incubator. What exactly for the incubator to do at an ICU? For the monitor, we need saturation monitor probe ready to be connected to the baby. We need ECG leads, 3 leads on the chest. We need blood pressure cuff. And we need invasive arterial blood pressure cable to connect arterial pressure if we done one. For the ventilator, we need to check the device connected to the circuit tube, connected to the test line, set already made, and the ventilation already started and tested on a test line. The humidifier of the ventilator need to be tested. And then we need to start the ventilator. And we need the setting mentioned already. So you can see, if you remember from the ventilation lecture, that we have pressure control, assisted control, plus volume guarantee. So this is our mode. We have the rate, 50, that's adjusted. PEEP, 6, that's adjusted. Inspiratory time, 0.38, that's adjusted. Slope or the ramp, 0.12, suggested. Starting FI to 30%, we might need to go up. Volume guarantee is 3 to 4.5 ml per kg. So we can make it here, volume guarantee. Okay, so this is the ventilator. We need intubation trolley. So we need ET tube with different size. So for 1 kg, we need 2.5 size. For 1 to 2 kg, we need 3 size. For 2 to 3 kg, we need 3.5 size. For 3 to 4, we need 4 size. We need stylet for the ET tube. We need circular mask. Remember, circular mask, very important. And 3 sizes, 0, 0, 0, and 1. We need laryngoscope. Okay? And when we have laryngoscope, we have to check the light is working. We need always extra battery for the laryngoscope, just in case stop working. We need the blade for the laryngoscope, size 0, 0, 1, 0, and 1. We need suction catheter to suction the mouth. We need size, French size 8, 10, 12, and 14. And we connect the suction tube to the suction pressure. And the suction pressure should be 80 to 100. We need a procedure trolley. So we need IV cannula, checked and ready. We need UAC and UVC checklist. I will show you the checklist. So in this case, for the peripheral IV, we'll have a checklist for peripheral IV and a checklist for UVC and UAC. We need medication for premature baby, ampicillin, gentamicin. We need caffeine. And this should be discussed with the doctor, because remember, from the ultrasound, we have expected weight. So from the expected weight, we should get the working weight. And we should calculate the ampicillin, gentamicin, and caffeine before the baby deliver. Also Cervanta, okay, need to be checked, and dextrose. And usually dextrose we start at the labor room before we transfer the baby. Okay, we also need to do arrangement at the OT or the LDU, labor and delivery unit. The temperature of the room should be 23 to 27. We need a resuscitator, for example, Ohio resuscitator. We need to set the temperature of the Ohio resuscitator to 37. We need 3 towels pre-warmed to room temperature. We need a cup to cover the head of the baby. If we will connect CPAP, then we will connect the hat of the CPAP. We don't need cover. We need a plastic wrap, and the plastic wrap is something like the sandwich zipper. So the zipper that we put the sandwich in. Okay, we need ambu bag. And again, we need circular mask with the sizes 0, 0, 0, and 1. We need the CPAP set, including the CPAP, the circuit, and the interface on the nose. We need trolley. I should have laryngoscope, check the light, So once you check the light, you tick it on. We need the blade of the laryngoscope, 3. So once you have 3, you check it on. We need the ETT. So you need 2.5, 3, 3.5, and 4. Once you've done that, you check the list. Stylet, if there is, you tick here. So you just click and it will be ticked automatic. Cannula, IV cannula, various size, at least 2 of each size. Tagadam, which is the rod that cover the lines. We need the IV flush, normal saline. We need 1 ml, 5 ml, and 10 ml. We need sterile gauze. So we need 2x2, size 2x2, and size 4x4. We need a spot bandage, so we can cover the pulse oximetry probe, the temperature probe, and even with the baby bleeding, so we can cover. We need gas syringe to do the blood gas from UAC or UVC. We need at least 3 gas syringe. Okay. We need vacutainer, which is an instrument to help you to do the IV line. We need the saturation monitor. Example, we use Massimo, for example. We need a glucometer, strip and lancet, so we can check the sugar. The medication that we need in the resuscitation room, we need adrenaline, we need caffeine straight, we need dextrose, normal saline, vitamin K, and we need eye drop. The incubator should have an oxygen cylinder because we'll use it for transport, and nasal cannula, and CPAP interface. We also will give you an information for parent with a premature baby. So we'll have a ready information that we will give it. So we have it in Arabic, in English, and in Kurdish. I will show it to you later. Need to be given to the parent, and parent read about the complication and the outcome and the survival rate. We need high-risk consent form. So the parent should sign on a paper. We'll tell them the risk, the complication, the time of stay, and the risk of death. Okay? And the checklist has to be signed by the charge nurse and the bedside nurse and 1 doctor, the general practitioner. Okay, so this is an example of a protocol. So, and I'm gonna stop here. And if you guys have any question. And I already shared with you the protocol. So I will give you the important protocol in future too. Questions?
Hello, doctor. I have a question.
Go ahead.
As I understand you, we have contact with the mother too, or just the baby?
No, we have to meet a doctor and a nurse, have to meet the mother and the father, explain to them what will happen to the baby. So usually they have 5 questions. Usually, is the baby going to survive or not? Second, most of the parents, they will stay, how long the baby will stay. Third, they want to know what's the complication, expected complication. Fourth, what is the cost? How much is it going to cost me? 5.
Also, we need...
Go ahead.
Go ahead, doctor.
Yeah, 5, they want to know when they can hold the baby, when they can see, take video and take, usually they want that. I'm going to see the baby, or they go to an ICU, when I can meet the baby, who can visit the baby, something like that. These are usual questions for the parents. So usually we answer that, and then we sign a consent, because I don't want them, once the baby die, because it's a premature baby, high risk of death, they go and complain to the nurses and doctors. So they have to sign a document saying that this is the risk of death, this is the risk of a complication, and I will not appear in any organization, legal or illegal, inside or outside Iraq, against any staff of the NICU, in person or as an organization, in anything related to the complications and the risk of death that's been explained to me by the doctor, thus and thus, and they have to sign. So they waive their right of going to the court. Otherwise, we'll not accept the baby. You understand? That's called consent form. So once we meet the parent before they deliver, we sign them this document. Otherwise, once the baby die, and we'll have very high death rate because all babies less than 1 kilo. So when you have 23 weeks, the risk of death is 70%. When you have 24 weeks, the risk of death is around 50%. So each 10 babies, 5 die. Do you understand? So we will end up sleeping in the court if they don't sign this document. Okay?
I understand.
That's what, yeah, so that's why we have to meet the parent. Yeah.
Despite the consent form, we need to take the history from the mother?
You don't take the history. You just say history was taken or not. This is a checklist.
Ah.
The history taken by the doctor. So you just say, doctor took the history. You checklist. If he did not, then you call him. Doctor, you didn't take the history. Okay? And if you refuse, this is not your job. You just say history not taken. You understand? You
Yes,
do
I
checklist.
understand.
Yeah.
Huh.
You prepare medications. You do temperature. So you don't prepare the temperature. The maintenance or the bioengineer check the temperature of the room. So once it's not been done, you just need to inform. Once you're informed, you just take inform. Okay? So not everything you do, but this is just a checklist, sorry. It was done or not done.
It's clear. Thank you so much.
Yeah. Any question? Once you practice, you will learn very easy because once you see it first case, you will have mistakes and that's normal. Second will less, second less. And then once we establish the unit, when there is a new people, you teach them. They will learn. They will come to the unit and learn. I don't need to teach them. I'm teaching now because this is the first time. You are the pioneer here. But otherwise, usually for the nurse, a new nurse, to come, within 3 months, she can take intermediate care. Within 6 months, she can take intensive care. That's usually the standard here. Once you join the unit, I will see she will learn. And one teach another, and so on. So with time, you will not need me. You will know. You will start teach me. Oh, you have to do this. You have to do this. You forget this. You do this. That's what nurses they usually tell me. Oh, doctor, you forget this. Are we going to do this? Because once the baby admitted in the unit, we will know what will happen in 3 months. So we will know what happened in the 3rd day, in the 7th day, on day 21, on day 28. It's all written. So, for example, when the ophthalmologist will examine, when the hearing will do, when the metabolic screen will do, when we'll start feeding, when we'll change the line, everything is written. So you just need in the morning to come and do the checklist. And if it's not done, need to be done. So, for example, cardiologists call other doctors, and you will start also participating in the morning round, team round. And you will present to us the case. This has been done. This is the order I give, according to what I show you in the first day, how to present a newborn baby. But with more information, you will learn. Questions? It's not difficult. And I was surprised. You guys are very good. I was surprised because everybody told me here the nurses are not good. But I was surprised. You guys surprised me. You're very good, actually. And you can be very good intensivists. And remember, intensive nurse are wanted everywhere and with very good salaries. Here is wanted and everywhere else in there. And once we start, I can assure you all the other hospital will do the same. So you are the pioneers. If you keep with me, you will see the difference. It's knowledge and business. Any question? Please ask questions. Anything. Feel free. Any abbreviation, any word you did not understand, ask me question. Because if no question, I have to go. No question?
Doctor, thank you also for that presentation. We must to read this checklist يعني, as a general. To me, it's like that. يعني, I must read that checklist. Then يعني, may I have a question?
Yeah, read the checklist and then label whichever one you did not understand. And let's meet again tomorrow and repeat it. So not tomorrow, Saturday we'll have the doctors. So Sunday, we can repeat the same. So at least you start to learn about the checklist. So when I give you transport checklist, you understand. When I give you UAC checklist, UVC checklist, surgery checklist, reception checklist, because ROB check or prematurity checklist, when the ophthalmologists come, everything is a checklist. So you don't need to worry, like apnea checklist, seizure checklist, pain scoring checklist, everything is checklist. You don't need, you just need to practice. So with the practice, you will learn yourself to do checklist, even you have not seen the checklist, this checklist, particular checklist before. So what I suggest to you now, you go and take this checklist, you print it if you can, and then read one by one and label it. And anything you did not understand, comment on it, and then ask me next time. Okay, so I'm going to repeat this checklist next Sunday, or at
Okay,
least
inshallah,
answering your
doctor. Thank you.
questions. Okay?
Tamam, doctor. Okay, inshallah.
And
But
don't worry,
for another,
don't worry, you're very good. I think you guys were very good. You're really good. I was surprised. You are better than 50% of nurses in Dubai. I'm not joking or I'm not exaggerating. You guys are very good. Your language are very good. Your personality are good. You're very polite. The only things I don't know about you is, are you disciplined or not? That's I need to see in practice. So if you are disciplined, you can be great nurses.
inshallah, doctor. Thank you for your opinion about us. But at another side, we have a point, please, doctor. If you can do a meeting beside Friday, because we have a problem in Friday.
Yeah,
يعني
so we
this
just
Friday,
choose which time. Choose the time.
at which week you can, doctor? That week or another?
I can from morning till 10, and from 2 till 5, and after 9. After 8, I can do.
Okay,
So
doctor.
before
Then,
10 a.m., between 2 p.m. and 5 p.m., and after 8 p.m. every day. Select a day and I will meet with you.
okay, doctor, that's good. Thank you. We will discuss about that, and then we will
Please.
tell you.
Yeah, we'll meet and practice. And we started creating the unit, and we starting bringing the devices. It's very difficult because some of the devices are not available here, but we'll bring it from China, from UK, because we already put the budget and we're bringing the machine. So you'll see machines that you never seen before. You'll see cooling machine. You'll see high frequency. Okay, you'll see inhaled nitric oxide. You'll see a transport incubator, transport CPAP, transport ventilator. You'll see medications. You'll see transilluminators. So you'll see everything like neonatology, real neonatology you've never seen before. So you will love it, I'm sure. Okay. And it's money, it's business. But your salaries is not with me. I'm not gonna. So the hospital will have agreement with you. Okay.
Okay, but may I know, will we start from the next month or next 2 months? And you
Plan
working
is to the first admission 1st of December.
1st December? Come on.
Yeah.
Thank you.
We if we can do before, but I don't think you are ready before, and we'll start giving shifts for those who knows how to put IV. So we'll start with those until the other lab. So you will be beside somebody who, but at least we have in the hospital a lady or a nurse that can put an IV. You understand? So that's a requirement. And for the doctors, we will have the doctor who know how to intubate. So these are two prerequisites to stay in the hospital alone or with somebody. However, we will have backup. So we'll have a vascular surgeon to help us just if we fail, and we'll have anesthesia to help us if we fail intubation. So these are like and I hope that I can sleep in the hospital in the first few months. Okay, so I help everybody until we build a team. Okay,
Okay, inshallah.
inshallah. Any more questions?